Where are you, Alex?
Dr. Pat.
Oh, there we are. You weren't on my first screen. So we're going to have a little spine discussion now. So without further
can everybody
ado,
see my slides?
We can see your slides and take over.
Okay. Sorry, you said you could see my slides? I was muted.
Yes, we can.
All right, great. Okay, for those of you who don't know me, my name is Alex Hysong. I'm one of the PGY2 orthopedic surgery residents. I'll be giving a brief talk today on lateral lumbar interbody fusions. I'll be going over a brief overview of the technique, indications, and outcomes of this procedure. This is a brief outline of my talk today. I have no relevant disclosures. To begin with, we'll start with some brief definitions. In terms of fusions, when speaking about lumbar spine surgery, there are three general categories. You have a posterior lateral fusion, which involves an arthrodesis between adjacent transverse processes, as well as the intratransverse membrane and adjacent facet joints. You have an interbody fusion where the disc is replaced with a cage or bone graft, encouraging arthrodesis of the anterior column of the spine. And you have a circumferential fusion, which is a combination of the above two techniques. In terms of approaches to the intravertebral disc for an interbody fusion, you have an anterior approach, which involves any approach anterior to the transverse processes and involves a retroperitoneal corridor to the lumbar spine. This includes the anterior lumbar interbody fusion, the OLIF or oblique lumbar interbody fusion, which is beyond the scope of this talk, and the focus of this talk, the lateral lumbar interbody fusion. And you can see the brief approaches or a depiction of the approaches down below at the bottom of my screen. Additionally, you have posterior approaches, the more traditional approaches to the interbody space, which is any posterior to the transverse processes traversing the spinal canal or the foramen and involves retraction of the nervous structures. So in general, why fuse the lumbar spine? Briefly, you have deformity and instability as one of the major reasons to do so. You have degenerative scoliosis and degenerative spondylolisthesis. Often these issues, when refractory to conservative management, lead to mechanical axial back pain and neurogenic claudication, which benefit from a fusion procedure. Additionally, you have redo surgery, such as a laminectomy, which has progressed to instability and worsening pain and adjacent segment disease. Brief history of interbody fusions. The first interbody fusion was performed in the 1930s. It was an ALIF performed by Burns, where he developed a retroperitoneal corridor to the L5-S1 disc base to treat a 14-year-old male who had a traumatic spondylolisthesis. He used plaster casting to immobilize the spine and was an overall successful procedure. In 1944, you had the first PLIF or PLIF developed by Briggs and Milligan, described to combat high arthrosis rates that were being experienced in spinal fusion procedures. And you had disc replaced with a round bone peg. In 1982, the first TLIF was described by Harms and Rollinger and was further developed by Harms in 1998. It was a unilateral approach with less sac retraction or thecosac retraction, and initially the bone graft was packed in a titanium mesh. In 1992, the first cage in humans was developed, the Bagby and Coolidge cage, and was used in a standalone construct in the lumbar spine. In 2001, after the development of MIS surgery in 2000, Luis Pimenta, a Brazilian surgeon, developed the first lateral trans-psoas approach to the lumbar spine. It was an endoscopic technique and was used to directly visualize the psoas muscle as it was transected for this procedure. In 2006, the modern technique for MIS LLIF, the technique we'll be focusing on in this talk, was developed by Barak Asghar using NuVasive equipment. The basic LLIF technique. The basic approach is a trans-psoas approach directly perpendicular to the intervertebral disc space. Abdominal musculature is bluntly dissected, and again, the psoas muscle is bluntly traversed. Intraoperative imaging is essential for this procedure as we need it to determine our perpendicular trajectory to the intervertebral disc space. As you can see here, one advantage over the traditional ALIF procedure is that you have access to multiple lumbar levels and even sometimes thoracic levels when performing an anterior interbody fusion. One thing to consider is the osseous anatomy of the iliac crest, as the L5-S1 disc space is often not accessible via this lateral approach. Additionally, more proximally in the lumbar spine, you have to be cognizant of the ribs which may be traversing the disc space and may need to be resected in order to access the disc. The patient is positioned in the lateral decubitus position. Electrodes are placed in the L2 through 5 myotomes. A mild break in the bed is used to open the disc space. We try to avoid overdoing this procedure or this technique of breaking the bed. The patient is secured with tape or a beanbag, and intraoperative imaging is used to ensure perpendicular trajectory, as I mentioned earlier. Neuromonitoring, as we'll see later, is essential for this procedure. Neuromonitoring is used to avoid direct injury to the lumbosacral plexus, which runs through and around the psoas muscle. In 2011, Tomei described discrete threshold electromyography, It is a technique where sequential dilators were placed over a positional K-wire in the intravertebral disc space, and 360-degree EMG, which is equipped in each of these dilators, is used to define the position and proximity of lumbosacral nerves. Decompression and cage placement, the final steps of this procedure. Blunt exposure is used to visualize the disc space. A self-retaining tubular retractor is used to maintain your position and allow for passage of instruments. A thorough disc preparation is performed. A cage is filled with a biologic material or allograft or a bone graft. It is placed spanning the apophyseal ring, and oftentimes these patients are supplemented with some type of either posterior fixation or lateral plating. Here is an intraoperative image that was actually taken at our institution of a patient who underwent a 2-level L-lift with posterior pedicle screw fixation. Relevant anatomy and approach-related complications. The superficial neuromuscular anatomy that surgeons must be cognizant of when performing this procedure are the abdominal musculature. The external oblique, internal oblique, and transversus abdominis muscles are bluntly dissected, and their innervating nerves, the subcostal, iliohypogastric, and ilioinguinal nerves, can potentially be disrupted early in the approach. If these are injured, there can be paresis of the abdominal wall, which results in a complication known as a pseudohernia, which is a unsightly bulging of the abdominal wall due to the hollow viscus pushing out against it. It is relatively rarely reported in literature and typically spontaneously resolves without any further complication. Of more concern to the surgeons performing this procedure is the deep neuromuscular anatomy. Particularly the psoas muscle, which I mentioned earlier, is directly transected during this procedure or traversed during this procedure. And this dense intervening network of nerves, particularly the genitofemoral nerve and the lumbosacral plexus, which you can see are all over the psoas muscle in that picture. Several studies have attempted to determine a safe zone for approach for this procedure. Rajev in 2009 reviewed MRIs of the lumbar spine and evaluated noted the position of both the ventral great vessels as well as the dorsal nerve roots of the lumbosacral plexus and defined the safe zone of entry into the intervertebral disc space. As you can see on this graph to the right, this safe zone sequentially decreases as you descend down the lumbar spine. This is mostly due to the ventral migration of the lumbosacral plexus. Uribe in 2010 performed a similar study, but it was a cadaveric study of 5 male cadavers, and he defined these safe zones and correlated it with lateral radiographic imaging. And as you can see, it correlates with a study from 2009 by Rajev, where you see ventral migration of that tubular retractor ideal position as you descend down the lumbar spine. Of note, neurological injuries are the most common reported complications following this procedure, particularly at the L4-5 disc space for obvious reasons. It occurs through direct injury to the nerves, traction injury of the nerves, and the rates of these complications vary pretty significantly in literature from 0.7 to greater than 30%. The most common complaints from patients are ipsilateral thigh numbness and hip flexor weakness. Several studies have looked at preventing these injuries. Uribe in 2010 said that the use of intraoperative EMG significantly reduces the risk of lumbar plexus injury, and he defined a specific less than 10 milliamps evoked potential as a safe distance or suggesting a safe distance from lumbosacral nerves. Uribe in 2015 stated that the duration of retraction during this procedure is a major contributor to neurologic complications post-op, and retraction time is less than 25 minutes as recommended. Le et al. And Achmar et al. Stated that the experience of a surgeon is highly correlated with the immediate post-op neurologic complications following this procedure, and that over time, as surgeons develop their skills and perform the procedure more quickly, as you would expect, these complaints are often decreased significantly. Other studies suggest avoid over-breaking the bed, as I mentioned before, as this can put undue tension on the psoas muscle and the intervening nervous structures. It is important to note that a majority of these complaints are transient and resolve over time. And of course, you have the hollow abdominal viscera intraperitoneally and the major vessels or the great vessels, the inferior vena cava and the aorta ventral to the vertebral body during this approach. Luckily, injuries are reported sparsely in literature, less than 1% in all categories. Thus, however, we should have a high index of suspicion when performing this procedure because these are potentially life-threatening complications. Briefly, indications and complications or contraindications for this procedure. Indications include scoliosis, most commonly degenerative scoliosis, spondylolisthesis, spinal stenosis, degenerative disc disease, and adjacent segment disease. Contraindications include severe osteoporosis, active infection, history of retinoperitoneal infection and disease, and previous retinoperitoneal dissection or injury, as you would expect, as this would prevent you from traversing the typical retroperitoneal corridor to the disc space. Again, pathology at the L5-S1 disc space is difficultly hard to approach as you have the iliac crest preventing your trajectory. Occasionally, the L4-5 disc space can be affected by this as well and can sometimes be inaccessible due to laterally traversing vasculature. So why LF? There are several purported or potential benefits that are reported in the literature. One of the biggest benefits or proposed benefits of this procedure is that you can place a large intervertebral graft or cage, and this should benefit patients in several ways. One is that it spans the dense apophyseal ring of cortical bone in the vertebral body, which should decrease the rate of subsidence. Larger graft footprints should again decrease the rate of subsidence and should theoretically allow for higher fusion rates. Larger grafts should allow for increased lumbar lordosis and improved sagittal balance. And finally, increased restoration of the disc space should allow for indirect decompression of neural elements. Indirect decompression is a very important concept when considering this procedure, because when you consider other posterior approaches, you have a direct decompression of the spinal canal. This involves laminectomy, flavum resection, and facetectomy. However, in this procedure, as I stated earlier, often posterior supplementation is done percutaneously, and there's no direct decompression of the neural elements. Rather, you place a large cage in the intervertebral disc space. You have a restoration of disc height. Ligamentotaxis allows for unbuckling of the ligamentum flavum. You have increased foraminal area and increased central canal space, allowing for decompression and relief of these neurogenic collication type symptoms that these patients were experiencing. This was directly studied in studies like this by Leonardo Oliveira in 2010, where he assessed X-ray and MRI images both pre and post-operatively after an L-lift procedure. He found that on all measurements that were obtained, there was a significant increase from pre to post-operative. Most significantly, foraminal area increased about 24%, and sagittal central canal diameter increased 33.1% after L-lift procedure. This has been further validated in other studies which have compared pre and post-operative imaging. This study performed by Elowitz also correlated this with positive patient outcomes and decreased patient-reported pain scores. Another potential benefit is the exposure and endplate preparation through this approach. It is theorized that direct lateral approach to the intervertebral disc allows for more thorough endplate preparation and thus for better incorporation of the graft that is being used. This cadaveric study by Tatsumi et al. Performed in 2015 compared X-lift with MIST lift, MISP lift, and mini-open A-lift, and qualitative and quantitative evaluations of endplate preparations displayed that X-lift had a larger area of endplate preparation as well as more thorough endplate preparation. Finally, there is theoretically a decreased approach-related morbidity, and this should afford the same benefits as other MIS techniques, such as decreased blood loss, decreased postoperative pain, and shorter hospital stays. So briefly, we'll go over the outcomes that have been found in literature regarding this procedure. First and foremost, we are attempting to fuse the spine. So does this actually effectively fuse the lumbar spine when performed? This systematic review in 2020 by Mustafa et al. Reviewed 22 studies of L-lift without posterior fixation or standalone L-lifts. 736 patients were included, 1,103 levels overall. Outcomes revealed a high 85.6 mean fusion rate ranging from 53 to 100% fusion per study, no difference in the number of levels fused or the addition of BMP2 in terms of fusion rates, and a 2.3% reoperation rate for pseudoarthrosis. Overall, a positive review of L-lift procedures. This more general study on the outcomes of L-lift performed by Yusuf et al. In 2010 retrospectively reviewed a cohort of 84 patients undergoing L-lift. Importantly, they did undergo various forms of supplemental fixation, including percutaneous pedicle screw and rod fixation, lateral plating, and some patients had true circumferential fusions. Additionally, 2 to 3 levels were fused in 39 patients, and the rest received only 1 level. So there was a wide range of results. Peri-op outcomes include average EVL of 155 milliliters, average overtime of 199 minutes, and an average length of stay of 2.6 days. Again, this is skewed by the wide range of procedures that were performed. Overall, the fusion rate was consistent with the study that was previously mentioned, with an 85% of patients with solid arthrodesis at an average of 15.7 months. Remaining patients did not complete their final follow-up and had no formal diagnosis of non-union reported. Patients reported that at 6 months, 92.7 had discontinued narcotics. VAS scores had improved by 77%, and ODI scores had improved by 56% at final follow-up. Another more standardized retrospective review of 600 patients undergoing L-lift for degenerative spinal canal conditions, performed in 2011 by Rogers, with 80% of patients receiving single-level fusions. Outcomes revealed a length of stay on average 1.21 days, a VAS pain score improvement of 65%, a blood transfusion rate of only 1 out of 600 patients. And at 1 year follow-up, 86.7% of patients were satisfied with the procedure, and 90.7% would have the procedure again. Importantly, in this paper, they also stated that at the time, length of stay for other interbody fusion techniques such as T-lift, A-lift, and P-lift had longer length of stays of on average 3 days. Blood transfusion rates were also higher in these other interbody techniques as well, though this wasn't a direct comparison, just a review of literature. They reported their complications, as you expect from the title from this study. There was a total of 37 complications out of 600 patients, rate of 6.2%. Importantly, 11 of these complications were operative, some for general surgery complaints such as gastric volvulus, and wound complications such as subcutaneous hematoma and hernia. But additionally, there were endplate fractures and other implant issues that required reoperation. Of note, the neural complication, which is frequently cited as the most common complication of this procedure, only occurred in 4 patients at a rate of 0.7%. It was quadriceps weakness, anterior tibialis weakness, and this all resolved within 3 months. Finally, in terms of another study reporting patient outcomes by Ahmadian et al. In 2013, reviewed 31 patients undergoing L-lift with percutaneous pedicle screw fixation for L4-5 degenerative spondylolisthesis. Again, patients had good outcomes with an ODI score improvement of 38.6%, SF36 score improvement of 56.2%, and a VAS score improvement of 44% at a mean average follow-up of 18.2 months following the procedure. In terms of complications, probably the largest systematic review of literature regarding L-lifts was performed by Hysong in 2017. It included 63 articles, including 6,819 patients undergoing L-lift, some with and without posterior instrumentation. They compiled the rates of complications and found, as we would expect, that transient neurologic complications were the majority of complications at a high rate of 36.07%. Transient thigh symptoms occurred at 26.51%, motor weakness at 14%, and hypoesthesia at 17%. Importantly, persistent neurologic complications, meaning after 6 months, were only at a rate of 3.98%. The rest had resolved. Operative complications, including ligament tears, occurred at a rate of 2.98%, vascular injury, as I mentioned before, at 0.4%, and bowel injury at 0.4%. Long-term complications such as pseudoarthrosis occurred at 5.89%. Importantly, compared to literature at the time based on this study, this was analogous to other interbody fusion techniques. Subsidence rate of note was 6.61%, and they stated that in other systematic reviews conducted at the time, A-lifts had a subsidence rate of 22%, and T-lift had a subsidence rate of 24%. Revision surgeries occurred in 2.19% of patients. Focusing a little more on subsidence rate, as this is one of the major benefits or proposed benefits of performing this procedure with a large cage. This study by Leah et al. Performed in 2012 retrospectively reviewed 140 patients undergoing L-lifts with various supplemental fixation. They were followed for 2 years to evaluate for evidence of subsidence through the end plates of the adjacent vertebral bodies. 22 and 18 millimeter cage widths were compared, and the outcomes were as follows. 14.3% overall subsidence rate, which is higher than you'd expect. But if you look at the 18 versus 22 millimeter cages, the 22 millimeter cages only had a subsidence rate of 1.9% compared to the 14.1% that is seen with an 18 millimeter cage. This suggests that, again, a larger surface area in a plate spanning or a cage spanning the apophyseal ring decreases the rate of subsidence and does provide a benefit for patients where this is performed. Supplemental lateral plate fixation had a slightly higher rate of subsidence than pedicle screw fixation. However, this was not found to be statistically significant, and 70% of subsidence occurred through the superior end plate of the bottom adjacent vertebra. Finally, as I said before, this can be used in degenerative kyphoscoliosis conditions, and several studies have reviewed this benefit on restoring lumbar lordosis and sagittal balance. Particularly this one performed by Sembrano et al. In 2015. It was a retrospective study actually comparing L-LIF, A-LIF, T-LIF, and posterior spinal fusion on their sagittal correction. Again, proposed benefit of the L-LIF is this anterior placement of a large cage should restore quite a bit of lordosis. Outcomes showed that overall, A-LIF had the highest or most significant improvement in lumbar lordosis, both segmentally and globally in the lumbar spine, most likely due to mandatory release of the ALL when performing that procedure. In second, L-LIF was provided the most lumbar lordosis, both segmentally and globally, and posterior spinal fusion did not have a significant improvement in lumbar lordosis. Importantly, when comparing other studies that have reviewed sagittal balance correction in the L-LIF procedure, this is the first study that showed both segmental and global lordosis improvements. This is theorized because there are some patients that underwent multiple level L-LIF procedures, and they believe that this was the reason for global return of lumbar lordosis or improvement in lumbar lordosis, whereas patients that only received one level L-LIFs did not have a significant difference. In summary, MIS L-LIF can be an effective technique for treating a variety of lumbar spinal conditions. Large interbody cage placement results in indirect neural decompression, improved pain scores post-op, and high fusion rates. Restoration of segmental, and in some studies, global lumbar lordosis is a benefit of this large cage. There are several approach-related complications, most notably transient neurologic injury. EMG use and surgeon experience have a significant impact on the rate of these complications, and a majority of these complications are transient. More head-to-head studies are needed, though, to validate many of the benefits proposed in literature. I'd like to provide a big thank you to Dr. Laxer and Dr. Kwan for reviewing this talk and for providing me with resources and very helpful advice. Thanks. These are my references.
Thanks, Alex. Great talk there, review of this topic. Again, we'll ask you to stop sharing your screen and have everybody turn their cameras back on. As we talk about subsidence, I know that bone quality is obviously an important issue there. Be interested in how people are using bone health assessment preoperatively in these patients. As a shout out to J.C. Holzinger, our long-term PA, who's developed a bone health clinic for us at Atrium within the Musculoskeletal Institute. I think she could potentially be a good resource for us in this. Thoughts on evaluation and/or treatment of osteoporosis preoperatively to prevent subsidence.
Josh, it's Eric. Let me just first of all thank Alex. I think that was an excellent summary and really well done. And just a comment that every now and again a procedure comes around that really can have a major impact on your practice, and this is a great example of that. And it's really helped us do a lot of things safely, especially patients who have had prior surgery and you want to try to avoid going back into their spinal canal. I think the issue of bone health is crucial, and I can say that most of us, not just for this procedure, but if we're going to consider a fusion on somebody, especially in certain demographics, over 50, female, people on steroids, they go through a preoperative bone health assessment, including a bone density, and we will refer them to a bone health clinic. So I think that cannot be overemphasized. That's extremely important.
Yeah, Josh, if I could chime in as well.
Please.
First of all, great talk, Alex. Great job. Great overview. You know, a couple issues. One, I think one of the issues related to subsidence with the lateral approach was the inability to kind of distract the disc space while you were putting in your spacer. And so you were trying to put in a spacer that was minimum 8 millimeters in height, sometimes as high as 8 millimeters and 12 millimeters in height, in a disc space that was very collapsed and without a real good way to mobilize the disc space like you do with A-lift or PLIF or T-lift. And so a lot of what was called subsidence wasn't really subsidence per se. It was actual end plate destruction on the way in. And as the technique evolved itself with expandable spacers, this was an area that I think expandable spacers really kind of revolutionized the idea of subsidence, because you were able to put in a spacer that started at 7 or 8, and even that extra millimeter or 2, and then get up to 9 or 10 or 11 or 12. You were respecting the end plates more. So I think a lot of what was subsidence was just end plate damage on the way in, and that technique, as it evolved, that kind of, and the instrumentation, including the interbody spacer evolution, has decreased that. The other thing that has evolved is really, as Alex talked about, is Pimented initially described a 2-incision blind technique where you stick a finger in laterally and stick a finger in posterior, retroperitoneal posteriorly, and then guided your distractors down. And then that evolved to a bigger kind of lateral one incision, but was still blinded. And then people talk about mini open direct look. And then that kind of evolved into a pre-psoas approach, where instead of going trans-psoas, you move pre-psoas, and it decreased the risk of femoral nerve injury, which was really big. So this has really undergone an evolution, as Alex talked about, of both surgical technique as well as instrumentation, that has really made the procedure even more reliable and safer.
Great, appreciate that historical perspective and input there, Dom. Any other comments? We're about out of time, but probably have time for one more comment if anybody wanted to make any.
Yeah, this is Tony Quantum, just chiming in. So obviously I do a lot of lateral type surgery. So, great talk, Alex. I think as far as reasons to, utilize this approach, I think all of us who do spine surgery would argue that, putting in a big implant, getting that indirect decompression, we're able to kind of get ACDF results, in lumbar surgery. And, I think this for me has been personally a big part of my practice. We all kind of joke that, ACDFs have such great outcomes and, great kind of clinical results, fusion rates. And I think we're taking some of those same concepts in the lumbar spine. And again, you kind of look at these implants and, I think it's hard to argue that, you'd rather have a T-lift or a PLIF versus a, lateral interbody cage placed in. So for me, it's been my kind of go-to procedure. I think that my results have been much better over my last, 100 patients versus my first 100. And kind of to Alex's point, I think the real kind of key takeaways from a technical standpoint are not breaking the table, being efficient in your, operative technique. And, really kind of to Dom's point too, is being mindful of end plates and avoiding the subsidence issue, because if you have subsidence, you kind of lose that indirect decompression. But I will say, utilizing some of these more kind of advanced, tips and tricks, I can't really think of the last patient I've had that has had significant thigh pain or, plexus type injuries. But great talk.
Great. Appreciate everybody's input. Thanks to all for your discussion this morning of both